colorectalcancerradio.com. Good morning. Thanks so much for being with us on what is turning into a very, very nice morning outside. Dr. Sam Kociola is with us this morning, and we're talking about colon cancer and colon cancer awareness. We met him a month or so ago when he was here with Dr. Clark, and this is a really serious topic, and so we want to get into it with him this morning. Our visit presented by Marcus and Mack, voted best law firm and best personal injury lawyer 4 years in a row in the Best of Indiana County contest. You can visit them online at marcusandmack.com. Good morning.
Good morning. How are you?
Wonderful. Good to have you back with us today.
Thanks for having me back.
It's always good to talk about topics of great interest, and this should be of great interest to a lot of folks.
Yeah.
Because colon cancer is so prevalent now, and especially in younger folks.
It is, yeah. Yeah, I think what March is Colorectal Cancer Awareness Month. I think it rightly deserves its month, alongside breast cancer and some of the other cancers that are prevalent. But yeah, it's depending upon what you look at, it's either third or fourth most common cancer in the United States, and then second or third most common cause of cancer deaths within the United States. So, but it's very preventable, which I think is all the more reason to get out and talk about it, and try to convince people not to just put it off or ignore it, because it's very easy to prevent in most cases.
Yeah, and that prevention is I don't want to say easier, but it is made much more approachable by the fact that we can now use genetics to help to predict. There are other tests that can help to predict. But the number one gold standard, of course, is the colonoscopy.
That's correct. Yeah, colonoscopies. I mean, there's at the end of the day, the best test is the one that you're gonna do. If you're not gonna do one, it's better to do one than not do one. But really, if you're gonna pick one to do one, I would say just do the colonoscopy. It's way better. It's the chance of missing polyps or cancers with a colonoscopy is far lower than any of the other tests. And a lot of the other tests, I mean, they're not bad tests, but if they are positive, like the Cologuard test, then it just reflexively prompts you to get a colonoscopy anyways. So it's convenient in that regard, but it has, a higher rate of missing precancerous polyps or cancers, compared to the colonoscopy.
Yeah, in talking with Dr. Clark and with others down through the years during Colon Cancer Awareness Month, I mean, we've really hit it hard.
Yeah.
And that's great. However, we get statistics like the one that came out a month or so ago that said that in younger folks, age 50 and younger, it's the only cancer that is increasing in terms of percentages.
Yeah, and I feel like I've seen that in actual real life practice too. It would be sort of unheard of to hear of colon cancers in 20 or 30-year-olds, a few decades ago, but it's not uncommon anymore. So, the old recommendation was to start colonoscopy screening at 50 years old, and now we've moved that up to 45, and I wouldn't be surprised if another decade or two it's 40 or even sooner than that.
Yeah, all right. And we've talked about the various causatives involved in that, and the American diet could be one of those
certainly.
cause factors.
Yeah, processed meats. Too much red meat. I mean, too much of a good thing is a bad thing. I love red meat and processed meats, but those are things you want to watch out for. Obviously, smoking, alcohol, the basic things that you learn, in elementary school. But yeah, there are certainly modifiable risk factors, and the American diet, you can't avoid it. We live in America, so
yeah, and obesity and lack of fitness,
sure,
that plays into it as well.
Absolutely, yeah, absolutely. All those things combined, it's usually not just one thing, unless you have a family history and an actual genetic condition that could lead you in that direction. But otherwise, it's multifactorial. It's a combination of all the above.
All right, so obviously you remove the polyp, you remove the chance that it can ever develop into a cancer.
Yep.
And so that's why you want the colonoscopy.
Yeah. I mean, so during the colonoscopy, we're looking for a bunch of things, but most notably for polyps. It's called the adenoma carcinoma sequence. That's the fancy doctor way of saying that. You have a normal cell that kind of goes awry and it turns into a polyp, an adenoma. And that has cancer potential in it, but hasn't actually turned into a cancer yet. And then eventually it can as it continues mutating. And that takes years, which is why, the typical recommendation if you don't have a family history of colon cancer and you don't have any polyps on your colonoscopy is another 10 years. You're good for 10 years.
Yeah.
But that can take time. And so those polyps, if they're small enough, we can actually pluck them out with the scope, with the colonoscopy, and, that tissue is gone. It doesn't have the chance to turn into a cancer in the future because it's, down in the pathologist lab.
Yeah. All right. So we start with the colonoscopy. If we do discover that there is colon cancer,
Yeah.
obviously there are things that you want to do and do as quickly as you can.
Yeah. Yeah. At that point, whether it's us doing the colonoscopy or GI doc or whoever's doing it, typically that will reflexively, get you down the pathway of towards surgery. So, there's a few things that we get ahead of time. Basic lab work. There's tumor markers. A lot of times people ask, if there's a blood test for potential cancer, why don't we just use that to screen? It's not used in that regard. We usually check that lab value before surgery, and it's something that after surgery we would continue to check to see, is it staying low. Initially it's usually pretty high, but then after the cancer's gone, that lab value will go down. And over time, if it starts creeping back up, that's usually an early indicator to be a little bit more worried. But we'll do basic lab work to get an idea of what you're starting out at, and then basic imaging, usually a CT of the chest, abdomen, pelvis, to basically ask or answer the question: is the cancer still in the colon, or has it spread elsewhere? And those places are typically, if it's going to spread, going to be the lung or the liver, sometimes bone.
Mm-hmm.
And that would change what we would do, from a treatment standpoint, because at that point in time, the cat's kind of out of the bag, for
Yeah.
lack of a better term.
If the cancer is contained just to the colon,
Yeah.
is the procedure always just remove that section of the colon?
Typically, yeah. There's different small nuances between colon and rectal cancer, but yeah, typically, if it is just within the colon, it's a low stage or an early stage cancer, and oftentimes surgery alone is curative. And part of surgery too, there's a difference with colon cancer surgery versus diverticulitis surgery. Think of the colon as not just a tube, but almost like a slice of pizza, and the crust is kind of where your actual bowel is, and then the triangle piece of the pizza is where the blood supply and the lymph nodes are. And so the way that cancer will spread, it'll start in the primary spot, and then it'll typically sometimes go to the lymph nodes next. They're kind of like checkpoints, and then from there it might go elsewhere. And so part of the cancer surgery is to try and get all of those lymph nodes. You can't really see them. They don't show up very well on imaging most times. Even in the OR, if they're really big, you might be able to see them, but oftentimes you can't. But we know that they follow the blood supply, they follow the vessels, and we can see the vessels. And so, again, to the pizza pie analogy, at the very base or the apex of that pizza is kind of the vessel. And so that's where we'll divide the vessel and then track all the tissue and gather all that tissue around it to gather as many lymph nodes as possible, in case it has spread from the colon or from the actual bowel wall to the lymph nodes. We've got all those lymph nodes, and if it hasn't spread to any of those, typically in that scenario, you're done. You won't really need chemotherapy after that.
Dr. Sam Kociola with us this morning. We're talking about colon cancer awareness. Obviously, the screening process will help us in this pursuit. But then if cancer is evident, then getting it taken care of is very, very important. When people are wondering or worrying, is this abnormal, what I'm seeing, blood in the stool,
Yeah.
or the way that I'm feeling? It's obviously not always an indicator of colon cancer, but something that you want to get checked out. What are the things that people should be looking for if they haven't had a colonoscopy in a while?
Yeah, if you're of age and you haven't had one, the first thing you should do is just get one, because oftentimes if you're noticing symptoms, that might mean that it's already progressed beyond the point of just being a polyp and actually a cancer. Because this is one of the few cancers that we can actually detect it, remove it before it even turns into a cancer, the polyps essentially. So by the time you're experiencing symptoms, you might have already developed something. But the things you really, if you see blood in your stool, dark stool, we call it melena, like a maroonish colored stool. Any change in the color of your stool in that regard, definitely get it checked out. Don't always just chalk it up to hemorrhoids. I mean, that's oftentimes what it could be, but you don't want to just hang your hat on that and then walk away. Fatigue, unexplained weight loss, those are things, or unintentional weight loss, those are things that you really want to be worried about, watching out for. Or any change in the caliber or consistency of your stool. If you're passing pencil thin stools, that's usually a bad sign.
Yeah, people wonder, about survivability. If colon cancer is detected, if it's spread to other parts of the body, obviously that makes a more complicated prognosis long term. But caught early,
right?
colon cancer can be removed, and you can have yourself a nice
Yeah.
long life.
Yeah. So yeah, not all cancers are the same. Colon cancer is much different than pancreatic cancer, is different than breast cancer, is different than lung cancer. So if you do find yourself having been diagnosed with it, don't despair, because we kind of track survivability as like 5-year survival rates. And so the 5-year survival rates for colon cancer, early stage colon cancer, is actually pretty good. For stage 1, meaning that it's just in the wall of the bowel after surgery, typically curative. You won't really need chemo after that. About 90 to 91% 5-year survivability rate. For stage 2, meaning it's gone almost all the way through the bowel or through the bowel wall, but not into the lymph nodes, survivability there is about 75%, usually just surgery alone. And then once it's made it to the lymph nodes, it's still about 70-ish%, so still not too bad. But then once it's gone to the lung or the liver, that's where it drops significantly to roughly about 15%.
Yeah.
But caught early enough, and that's why screening is so important. Again, if you can find the polyps, they're gone. But if you do find a cancer, if you're doing your screening and the appropriate time intervals, ideally you catch it when it's early.
Yeah.
You may require surgery, which isn't ideal, but the survivability is actually relatively favorable.
So hopefully during this month of colon cancer awareness spots, we have encouraged people to get started in this process. But there may be people who are sitting there saying, all right, I've resisted until now. You finally convinced me, but they don't know where to start. Where should people start?
Yeah, honestly, your primary care doc is probably the simplest and easiest place. See if they've got a good avenue, pathway to get you plugged in, or just call our office, the GI office. If you go to Google and just type in IRMC surgery or IRMC gastro or GI, and they'll have a number listed there. We're happy to get you in to do colonoscopies. It's part of our job. It keeps us busy. They're usually quick and easy too.
Mm-hmm. Yeah.
Yeah.
Get it done.
Yeah.
The prep is not that bad.
That's the part. Yeah. I mean, that's the thing that I wish maybe one day we'll have an easy way of doing the bowel prep, but it really is important to have a good bowel prep, because you need to be able to visually see everywhere in there. If you're still covered in stool on the inside, we're not going to be able to see anything. So yeah, that I can't really sugarcoat that. Maybe not the best phrase to use there, but yeah, you just grin and bear it. It's one night for potentially a decade of reassurance and peace of mind.
Yeah. Got to get it done.
Yeah.
Got to get done. All right. Hey, I appreciate you and all of your colleagues talking about colon cancer this month. It's something that treatable, preventable, and we really need to be aware of.
Yeah. No, thanks for having me on again. It's a pleasure to be able to help serve in this way.
He's Dr. Sam Kociola joining us here this morning on Indiana in the Morning.